Thank you very much, Brian. I started working with Jenny, Brian, Greg, and the crew not all that long ago, but ever since I've been working with them, I've been incredibly impressed, with what they've done. We've got a lot of wonderful resources available for myeloma patients through a variety of different organizations. But certainly, you guys have done an absolutely fantastic job. So certainly use them as a resource as you go through your treatment options going forward. So we can get to the most exciting topic of the day, the emerging immunotherapies for treatment of multiple myeloma. I'm going to go through this presentation relatively quickly. I'm going to be talking about treatment options for patients, who have relapsed after their initial therapy. So I'll talk about treatment or patients who have, relapsed early in the course of their disease, later in the course of their disease. I'll talk about some of the emerging therapies, not the immunotherapies that Adam's going to talk about, but some of the other small molecules that are currently in development. And then I'll just show you some general principles that we use to guide therapy. And I think as I walk you through those, you'll become increasingly cognizant of why, having a myeloma specialist involved in your care can be helpful, because the options are many and the nuances to treatment choice are considerable. So let's start by talking about treatment in early relapse. And by early relapse, I mean patients who are maybe in their first or second relapse, for example. I'm not going to go through this entire list. Suffice it to say that we have a large number of combination chemotherapy strategies available for patients with relapsed multiple myeloma, much of which is predicated on level 1 evidence. And by level 1 evidence, I mean a large phase 3 randomized trial has proven beyond the shadow of a doubt that there's efficacy of that particular regimen. This was extracted from the NCCN guidelines, which gets updated on a regular basis. So there are a large number of phase 3 studies that have been published in the New England Journal of Medicine over the course of the last couple of years. So the first thing I'll do is talk about 4 phase 3 studies that looked at lenalidomide or Revlimid and dexamethasone with either Dexamethasone-Based or Ninlaro, that's the Tourmaline study, RevDex with elotuzumab or Emplicity, that's Eloquent-2, RevDex with or without Carfilzomib or Kyprolis, that's the Aspire trial, and then RevDex with or without Daratumumab or Darzalex, which is the Pollux study. And several take-home points here. First off, without exception, overall response rates increase with the addition of the third agent across the board. This is particularly striking for patients where the Carfilzomib was added to the regimen, 68% response rate versus 87%. Similarly, when you add Daratumumab to RevDex, about 76% response rate versus a 93% response rate. Very good partial response means 90% or greater reduction in disease burden. And what you can see here is in several of the studies, the proportion of patients who have a deeper response is higher with the addition of the third agent. With Dexamethasone, not so much with elotuzumab, but we'll talk about progression-free survival in a moment, but certainly with the addition of Carfilzomib and with the addition of Daratumumab as well. And in every single one of these studies, progression-free survival was improved with the addition of the third drug, Dexamethasone, elotuzumab, Carfilzomib, and Daratumumab. We actually have some data on long-term survival with the addition of Carfilzomib to the RevDex backbone, and we actually have an improvement in median overall survival of about 8 months for those patients that had Carfilzomib or Kyprolis added to their Revlimid dexamethasone backbone. Now the caveat to this is that a large number of phase 3 studies are performed internationally, and access to Kyprolis and subsequent lines of therapy may be somewhat compromised in other parts of the world. So a lot of the patients that were randomized to the RevDex arm of this trial, say like in Brazil, for example, may not have had access to Kyprolis in a future line of therapy. So you always have to take these data with a grain of salt. But the bottom line is this is a very powerful regimen. And we hope with longer follow-up we'll see an improvement in overall survival with some of these other studies as well. Now, the magnitude of benefit with regards to overall response, deep responses, and potentially survival seems to favor of the addition of the Carfilzomib and Daratumumab, but what I would argue is that there can be subtle differences in the patient populations that are treated in one study versus another. So these cross-trial comparisons that we make always must be taken with a grain of salt. So that's one thing. And then the second thing I'll mention is that the addition of Dexamethasone or elotuzumab to the RevDex backbone is incredibly well tolerated. When you look at the side effect profiles in these phase 3 trials, most of the side effects are coming from the RevDex. The addition of the Dexamethasone or the elotuzumab to the backbone, it is adding some toxicity, but not a tremendous amount. So we've got, 4 wonderful, RevDex-based triplets that now have level 1 evidence to support them. I think that the challenge that we have, though, as we talked about previously, Revlimid maintenance therapy is typically given until disease progression as long as the patient's tolerating it. So a lot of patients in their first relapse already have Revlimid-resistant disease. So what do we do with those patients? So here are several phase 3 studies that looked at Revlimid-free, proteasome inhibitor-based therapies in the early relapse space. So there was, and in here, Velcade dexamethasone is the comparator. So you have Velcade dexamethasone with or without the histone deacetylase inhibitor Panobinostat or Faradec. You have Endeavor, which was not a doublet versus a triplet. It was looking at 2 different doublets. So Velcade dex versus Carfilzomib or Kyprolis dex. And then you have the Castor study that Dr. Usmani talked about, Velcade dex versus Daratumumab Velcade dex. So with regards to the Panorama 1 study, there was a trend towards improvement in overall response rate and deep responses. There was a statistically significant difference in median progression-free survival, but the regimen was hampered by a lot of toxicity, fatigue, gastrointestinal side effects, and low blood count issues. So this had a hard time getting across the finish line with regards to regulatory approval. But what the FDA did is, there were some pre-planned subset analyses that were built into the study. And what they found is that for patients that had had 2 prior therapies, including an IMiD such as Thalidomide or Revlimid, as well as Velcade, the improvement in progression-free survival is very different, with the addition of the Panobinostat. And it's in this group of patients that this particular regimen got approved. Nonetheless, a challenging side effect profile for sure. Now, interestingly, Carfilzomib dexamethasone outperformed Bortezomib dexamethasone with regards to response rate, the rate of high-quality responses, and it nearly doubled the median progression-free survival. Now, you can argue why this is the case. Maybe Carfilzomib is a more potent proteasome inhibitor, but I think a lot of it is driven by the fact that one of the challenges that we run into with regards to long-term Bortezomib administration is peripheral neuropathy. So you oftentimes find up having to adjust the dose schedule or the dose itself, and sometimes stop it altogether as neuropathy issues accumulate, whereas you don't have that problem with Carfilzomib. Now, going to the Castor trial, the addition of the Daratumumab to the Velcade dex, again, significantly improves overall response rate as well as the likelihood of a deep response. But data with regards to overall survival are still very premature. So what about treatment of later relapse? And in particular, patients who have had at least 2 prior lines of therapy or patients who are double refractory. This is data basically looking at patients who have relapsed refractory disease. And, for those patients that were refractory to Velcade and had received at least 1 prior IMiD therapy, median overall survival was 9 months. Now, this is somewhat outdated data. It didn't take into account Daratumumab and things of that nature, so I wouldn't get too freaked out by what I'm showing you here. But as the disease becomes increasingly refractory, outcomes, aren't as good, and we certainly need novel ways of treating those patients. So these are the NCCN guidelines for available regimens for patients in later relapse. Again, patients who've had at least 2 prior lines of therapy or may have more drug-resistant disease. And the bottom line is that there's a lot available to choose from, much of which is Pomalidomide Dexamethasone-Based. And that's as a result of this particular phase 3 study, which is fairly old at this point, which randomized patients with heavily pretreated disease to either Pomalyst and dexamethasone, or then what was a standard of care for refractory disease, high-dose pulse dexamethasone. Patients in this study had had a median prior lines of therapy of 5, and 3/4 of the patients in this study were resistant to both Revlimid and a proteasome inhibitor, in most cases Velcade. And what we saw here is that the response rates were tripled, the median progression-free survival was doubled, although we can certainly do a lot better than 4 months, and survival was improved as well. So Pomalyst and dexamethasone serves as the new backbone for a lot of the triplets that are currently being studied in the new wave of phase 3 studies. So we use a lot of Carfilzomib with Pomalyst and dexamethasone. That's not based on phase 3 data, and we'll never get that phase 3 data, but it's based on solid, albeit relatively small, phase 1-2 experience. So this was a study that was spearheaded by the MD Anderson group, basically looking at Carfilzomib, Pomalyst, and dexamethasone for relapsed refractory myeloma patients. Median prior lines of therapy was 6. Everybody had Revlimid-resistant disease, and nearly everybody had Velcade-resistant disease. And in spite of that, the overall response rate was 50%. When we look at what we call minimal responses, which is a 25 to 50% reduction in disease burden, 2/3 of patients derive benefit. And the median progression-free survival was 7.2 months. Again, we have to do a lot better, but that's certainly better than the 4 months that we saw with just Pomalyst and dexamethasone alone, and perhaps a less refractory patient population. So there have been 2 phase 1/2 studies of adding Velcade into the Pomalyst dexamethasone backbone, one of which was done at the Mayo Clinic. The other one was spearheaded by the Dana-Farber Cancer Group. I'm not going to belabor the details. Suffice it to say that the response rates were quite favorable, particularly in the less heavily pretreated patients in the Mayo Clinic study, an 85% overall response rate and a median progression-free survival of almost 11 months. And both of these studies kind of gave way to a phase 3 study called the Optimism trial, which was basically looking at Pomalyst and dexamethasone with or without Velcade. And they had a press release a number of months ago now saying that their primary endpoint, progression-free survival, was met. So we'll probably see those data presented at ASCO in the relatively near future, and my strong suspicion is it's going to be a very positive study and will likely lead to yet another regulatory approval of a triplet in patients with relapsed multiple myeloma. Daratumumab, so this again is the monoclonal antibody that binds to CD38, which is a protein that's highly expressed on plasma cells, including malignant plasma cells of multiple myeloma. This is the combined phase 1-2 early experience of daratumumab by itself with nothing else for patients with highly resistant disease. And even though these patients had very refractory disease, there was actually a 30% overall response rate. That means 70% of the patients did not respond to therapy, but the fact that they responded to anything was really quite remarkable. And to be able to do that with just a single monoclonal antibody that's fairly well tolerated was really quite impressive. And median overall survival was close to 20 months, which is unheard of in a patient population of that nature. So that kind of fueled all of the subsequent daratumumab studies that have been pouring forth ever since. We use a lot of this particular regimen, and it's based largely on this study. So Pomalyst, dexamethasone, and daratumumab for relapsed refractory myeloma patients. So this was a study that was presented and now published by Dr. Chari at Mount Sinai. Median prior lines of therapy for these myeloma patients was 4. 70% of patients had what we call double refractory disease, so refractory to a proteasome inhibitor as well as an IMiD, and 1/4 of the patients had high-risk cytogenetics, which we've talked about before. Overall response rate was 60%. There was a fair number of very good partial responses and better, as well as complete responses and stringent complete responses. Median progression-free survival was 8.8 months, fairly respectable in a heavily pretreated relapsed refractory patient population. These are data that the Emory crew presented at ASH 2 ASHs ago. They were interested, so the idea is that an IMiD like Revlimid or Pomalyst may have a role in the context of monoclonal antibody-based therapy, even if the disease has become resistant to those particular agents. And the reason for that is not only do drugs like Revlimid and Pomalyst have direct cytotoxicity against myeloma cells, but they can actually increase numbers of natural killer cells and activated T cells in circulation, which are the guys that are responsible for killing antibody-coated cancer cells to begin with. So the idea is you might be able to take advantage of that particular mechanism of action and use Pomalyst in the context of DARA-based therapy and get activity even when the drugs individually stopped working. So in this particular analysis, 12 of the patients, granted this is a very small number of folks, had disease that was refractory to Daratumumab as well as Pomalyst in prior separate lines of therapy. And despite that, 4 of them had at least a 50% reduction in disease burden. They were refractory to the individual agent. So when you brought them together, you were able to recapture response. So there's a lot of interest in better sorting that out as to why that might be happening. So I mentioned the Panorama 1 study briefly. That was the phase 3 study of Velcade and dexamethasone with or without Panobinostat. For the toxicity issues that I mentioned before, we don't use it in its labeled indication all that often. This is the type of scenario where we might use it more often. So this was a very interesting study that was published a few years ago now, which was a single-arm phase 2 study of Velcade, dexamethasone, and Panobinostat in patients who had documented Velcade-resistant disease. Now, this is important because Panobinostat, as a single agent, has 0 activity against myeloma. So we would not expect these patients to respond to therapy solely because you're adding in the Panobinostat. So they had 55 patients in this particular trial. Median prior therapies was 4. Median time since diagnosis, was over 4 years. And, what they saw was a response rate of almost 35%. And when you take into account the minimal responses, a little over half of the patients derived some benefit. Median progression-free survival was 5.4 months. So we will sometimes use a proteasome inhibitor in combination with Panobinostat for patients who are fairly fit, who have started to run out of options for their disease. So let's just quickly touch on emerging therapies. Again, I'm not going to be talking about immunotherapy. Saad talked about venetoclax a bit. Again, this is something that appears to have particular activity in a select group of myeloma patients. So venetoclax is a BCL2 inhibitor. BCL2 is a protein that's expressed in a number of different malignancies and helps them resist cell death. So the higher your BCL2 level is, the more resistant you are to dying and more resistant to chemotherapy. So the idea is if you design a drug that will bind and inhibit BCL2, you can restore sensitivity and promote cell death in those cells. So this is a study of venetoclax by itself for heavily pretreated myeloma patients. Median prior therapies was 5. Almost everybody had gotten Velcade and Revlimid previously, and the majority of them were refractory to those agents. Importantly, when you look at the overall response rate, it was 21%. So about 1 out of 5 patients had at least a 50% reduction in disease burden. But when you look at the patients who had the 11-14 translocation, the overall response rate was 40%. Not only that, but a lot of those were very good partial responses, complete responses, and stringent complete responses. So there's clearly something about 11-14 that is much more, that's enriched for disease that's more BCL2 dependent than your other non-11-14 translocated disease where the overall response rate was only 6%. This study has since been expanded in a phase 2 fashion for accelerated approval, and we strongly suspect that that will happen sometime in 2019. Now, we've talked before that, precision medicine is the future, but in multiple myeloma, given the heterogeneity of the clones, that the precision medicine maybe needed to be added to a combination. So venetoclax has been looked at in combination with Velcade and dexamethasone. And the reason for doing this, I don't want to belabor the details, but there's some thought that Velcade can indirectly downregulate the levels of another protein that helps cancer cells resist cell death, something called MCL1. So the idea is that you inhibit the anti-cell death protein BCL2 with venetoclax, you knock out MCL1 with Velcade and see what happens. So this is a phase 1b study of this particular triplet. Bottom line is that the overall response rate was about 2/3 when you look at all comers, but I want you to focus on the patients who did not have Velcade refractory disease and were less heavily pretreated. So these are patients who had 1 to 3 prior lines of therapy, and the response rate was close to 100%. That's better than you might expect with Velcade and dexamethasone alone, and it suggests that there may be some benefit even to the non-11-14 patients when used in a combination setting. So it'll be interesting to see how this plays out going forward. There is an ongoing international phase 3 study looking at Velcade and dexamethasone with or without venetoclax, regardless of 11-14 translocation status. Selinexor might be something that you've heard about. Selinexor is a small molecule inhibitor with a completely novel mechanism of action. It works completely distinctly than anything else that's out there in myeloma. It's an exportin 1 inhibitor or XPO1 inhibitor. What the heck is exportin 1? Exportin 1 is a protein that sits at the surface of the nucleus of the cell, and it basically functions to shuttle proteins from the nucleus out into the cytoplasm of the cell. And where a protein is located can impact its function. Now, interestingly, there's a number of different tumor suppressors that get locked into the nucleus where they're supposed to be when you treat the cells with exportin 1 inhibitor, selinexor. Interestingly, too, there's something called the glucocorticoid receptor. So when you get treated with dexamethasone or prednisone for your myeloma, the dexamethasone crosses into the myeloma cell, binds to the glucocorticoid receptor, which goes into the nucleus and then promotes transcription of a variety of different genes. Now, if the glucocorticoid receptor is trapped outside in the cytosol, it can't mediate its effects. And one of the reasons why that happens is because the glucocorticoid receptor can get shuttled out of the nucleus into the cytosol by exportin 1. So if you plug up that hole, you can actually accumulate glucocorticoid receptors in the nucleus and kind of restore sensitivity to steroids. And interestingly, when this drug was first being developed, when it was given by itself, it really had very marginal activity. But when you give it with dexamethasone, not only does the dexamethasone help with the nausea that the drug causes, but the responses seem to be a bit more robust. So this is the STORM study that was published in the Journal of Clinical Oncology by Dr. Cohen's colleague, Dan Vogel. So this is a phase 2 study of selinexor plus dexamethasone in heavily pretreated patients. So 48 of the patients had what we call quad refractory disease, Revlimid, Pomalyst, Kyprolis, Velcade resistant disease. 33 patients had 5-drug refractory disease. So they were refractory to all 4 of those drugs plus Daratumumab. And in spite of that degree of refractoriness, we saw a response rate of about 20%. Now, again, 80% of patients not responding to therapy, but the fact that they're responding to it at all, very encouraging. Now, like Panobinostat, this is a drug, that does have some toxicity issues, fatigue, blood count issues, and gastrointestinal side effects. So we'll need to learn how to better manage the side effects, if this is going to see, the light of day in the future. But there's an ongoing study in heavily pretreated patients that will hopefully buy this accelerated approval. Now, I'm going to talk about general treatment principles at this point, just to kind of let you know what I think about as I'm making decisions for myeloma patients. I've shown this slide before, so for some of you that have been here before, I apologize about that. So PAPST is the acronym that I like to use to kind of guide you through the decision-making process that I use to determine how on earth am I going to decide how to treat you with all of these bazillion different treatment options available to you. So P stands for past medical history. What medical conditions do you have that will impact tolerability? If you have out of control high blood pressure, congestive heart failure, Kyprolis may not be your best friend. If you have severe neuropathy, like Dr. Cohen talked about, Velcade may not be your best friend. What adverse events? A, what toxicities did you experience with prior therapy? If you had really bad neuropathy with Velcade in frontline therapy, a Velcade-based combination may not be your best idea in the relapse space. B is biochemical versus clinical progression. So are the numbers getting worse but the patient isn't sick? Or does the patient have new bone pain or advancing renal dysfunction because their disease is growing wildly out of control? If you have clinical relapse progression, you have very little margin for error. You need something that you know has a high probability of working and working fast and producing a deep response. Whereas if you have somebody with low-risk disease who's in a biochemical progression, you have a lot more latitude as far as how you treat that patient. Do they have standard or high-risk disease biology, as we've talked about before? And really importantly, what is their treatment history? What treatment have they had in the past? What classes of agents is their disease resistant to versus not? Now, can we make treatment choices based on cytogenetic risk? We've talked a lot about this in my previous talk, and the answer is there is some emerging data to suggest that, some of these newer combinations may not necessarily overcome the high-risk cytogenetic features, but certainly work better than what we had before. So going to the ASPIRE trial, just as an example, I've broken it out into standard risk and high-risk patients here. High risk is defined by deletion 17p, 414 translocation, or 1416 translocation. And what you can see in the high-risk patients is that the addition of the Carfilzomib clearly makes a difference. There's a higher rate of good quality responses, and the median progression-free survival is clearly improved, and the magnitude of the effect is just about as good as it is in the standard risk patients. That said, the control arm does better in the standard risk patients, so the absolute magnitude of the effect is more pronounced in the standard risk patients. So, it doesn't completely overcome the negative risk associated with these cytogenetic abnormalities, but it certainly improves it. And we have similar early data with Pollux, with the addition of Daratumumab. We do have some data with Velcade Dex versus Carfilzomib Dex in this regard. I'll tell you this, that there was an improvement in overall response rate and high-quality responses with Carfilzomib Dex compared to Velcade Dex. But look at this, median progression-free survival of 6 months versus 8.8 months. So I would argue that this isn't good enough. So for patients with high-risk disease, cytogenetic disease, and relapse, you really need a triplet. A doublet's probably not good enough for that reason. The Tourmaline data is very interesting in this regard. So when you look at the high-risk patients, when you look at the control arm, RevDex, median progression-free survival is clearly inferior, in the high-risk patients compared to the standard risk patients. But when you look at the median progression-free survival in the standard risk and high-risk patients, it's exactly the same, which would suggest that it's actually completely overcome the high-risk cytogenetic marker in that particular study, which is really quite remarkable. This is a breakdown of what I just talked to about, so I'm going to go on from that. Pomalidomide, or Pomalyst-based therapy, also appears to be working well in deletion 17p disease, as Dr. Usmani had alluded to. This is data from that phase 3 trial that I showed you previously. And suffice it to say, if you had deletion 17p, you did just as well as those who did not have deletion 17p, whereas those who had the 414 translocation didn't do as well. So this would suggest that the PomDex overcame the high-risk marker of deletion 17p, but not of 414, whereas both deletion 17p and 414 translocated patients did poorly with dexamethasone compared to the standard risk patients. So going to treatment history, I'll always ask myself, what regimens has the patient had in earlier lines of therapy? And is the disease refractory to a specific treatment? I will argue that Carfilzomib has documented activity in Velcade and in Laro refractory disease, but the reverse has not been well studied. Similarly, Pomalidomide and Pomalyst, as we discussed in the previous session, has activity in Revlimid refractory disease, but the reverse hasn't been necessarily proven. If the disease is refractory to a particular agent, did the patient progress on standard dosing or reduced dosing in the context of maintenance? Or were they dose reduced because of prior toxicity? And if so, what was that toxicity and could it have been managed better? So there's all these little nuances that you have to address when trying to come up with the best treatment strategy for your patient. So I'm going to skip that. So just to kind of conclude, there are many right ways to treat patients with multiple myeloma and relapse. There are also wrong ways to do it, which is why having a myeloma specialist available to you can be helpful. As long as you have that PAPST and review those 5 steps, I think you'll always come up with a good answer. Again, use the myeloma specialist as a resource, even if you live a long ways away from them, maybe touch in with them periodically. And lastly, always consider a clinical trial, because while we've gotten certainly better at treating this disease, we certainly have a long ways to go. Thank you very much.